All right, Kristen, thank you for keeping an eye on the folks coming in. We're going to go ahead and get started. So again, welcome to our webinar delivery. This is part 2 of the 4-part national series, What's Next? Implementing Injectable PrEP. As this is part 2, it is hosted by the University of Rochester Center for Community Practice. And this session is going to be on implementing injectable PrEP and specifically looking at some lessons from the field. My name is Mike Wilson. My pronouns are he, him, his, and I'm going to be your moderator as we're going through the day today. And if we can go ahead and go to the next slide. I'm going to hand things over to our interpreters that are available from Tilde, so please feel free to take it over from here.
Thank you so much. Hello, everyone. Hola a todos. Today we are facilitating a multilingual space. Hoy estamos facilitando un espacio multilingüe. Para acceder a la... Si usted no es bilingüe en español e inglés, por favor que escuchen este anuncio. Para acceder a la interpretación por computador, seleccionen el icono globo al fondo de su pantalla y después que seleccionen su canal de idioma o español o inglés. Si están accediendo a la interpretación por teléfono inteligente, por favor seleccionen los 3 puntitos, después interpretación de idiomas y después su canal de idiomas o el inglés o español. Hello everyone, today we are facilitating a multilingual space. If you are not fully bilingual in English and Spanish, please listen to this interpretation announcement. To access interpretation by computer, please select the globe icon at the bottom of your screen, then select your language channel, either English or Spanish. Additionally, is there another slide in English perhaps?
Yes, there is, Kai.
Thank you. Great. Select the globe icon and then your language channel, English or Spanish, if you are accessing interpretation via computer. And if you're accessing interpretation via smartphone, please select the 3 dots on your screen, then language interpretation, and then your language channel, either English or Spanish. Please remember to speak slowly at a moderate pace for interpreters and to speak 1 person at a time. Por favor, que se recuerden de hablar una persona a la vez y de hablar despacio para los intérpretes. Thank you so much. Muchas gracias.
Thank you, Tilde. Our interpreters from Tilde are Kai and Megan. They will be broadcasting in Spanish simulcast throughout this webinar. Thank you for setting that up for us. As a reminder, this webinar series is a part of a collection with the Capacity Building Provider Network, more commonly known as the CPN, as designated through the CDC's Capacity Building Wing. Ourselves at the University of Rochester Center for Community Practice are hosting the 2nd session. The 3rd session is going to be hosted by our partners at the Washington University in St. Louis. And the final session is going to be hosted by our partners at Hands United. The 1st session was hosted by the San Francisco Department of Public Health. And the recording of that has gone out to participants as well. If you need any of the resources from the 1st session, don't hesitate to reach out. We will be able to make sure that you get those. Again, this webinar is part 2 of our 4-part series. So today we will be talking about implementing injectable PrEP, specifically looking at some lessons from the field. I want to note today that we will not be talking about financing, as that's going to be covered in session 3 in October by our friends at Washington University. And then our final session is going to look at putting things together and connecting with technical assistance through our partners at Hands United at the Latino Commission on AIDS in November. Just a few things to keep in mind. Our speakers during the presentation today will be on camera, so you'll be able to put a face to the voice that you're hearing. We will have multiple speakers later on during a panel, so we'll all be on camera during that time. As you can notice, you'll need to use the QA function to put in questions and to connect with folks in the chat. There are a lot of us signed on to this webinar today, so we have closed down the regular chat and are using the QA function for today. As we noted earlier, this webinar is being simulcast in Spanish. Both the English version of this webinar and the Spanish interpretation are being recorded and will be available after the webinar has been completed. At the end of the webinar, we will have an evaluation that we are asking everyone to complete. So please make sure that you take some time to do that. And finally, if you are having any technical assistance issues while you are on this webinar, please don't hesitate to reach out to our producers using the Q&A function. Our producers for this webinar are Holly Eckelberger and Kristen McKay, and they'll be able to help you with any of your tech needs. This webinar is going to have, we're doing our intro here. We're going to do some polling questions to see where folks are at right now. Then I'm going to hand things over to Dr. Daniela DeMarco with the University of Rochester's team, who's going to take a look at a bird's eye view of injectable PrEP implementation with a newly cleared CDC document. And then we're going to hear some presentations specifically from the field. So we have Toby Fugate from Charleston, South Carolina, Leanna Ramirez from Las Vegas, New York, and Justin Toro from New York City, all going to talk about their experiences. What I will say during the presentations, we will not be answering questions from the Q&A, but we will be answering them during the panel. So feel free to put your questions in as you see fit, but we will be answering them during the panel. So if you can take a moment to join us on Poll Everywhere, we're going to take a moment to see where everyone's at this point. So feel free to scan this using your phone, or you can go to the link that's on the slides. It has also been added into the chat for everyone. Take a moment to get yourself connected, and then we'll take a look at the questions. All right, so first of all, what single word would best describe your job role or your job title? If you're using more than one word, just put a dash in between the two words so that you can just combine them together. All right, I see some answers coming in. The most common answer is going to be largest. I see in the Q&A we had prevention added in. Great, so it appears that what I most commonly see in our nurse, we have some coordinators, we have some managers, we have some PrEP coordinators, some PrEP navigators in here as well. So it sounds like we've got a good mix of folks who are clinical providers and then some non-clinical providers who support clinic staff or support prevention efforts. Awesome. All right, let's go ahead and take a look at the next one. See additional patient navigator added in to the chat. All right, where are you or your organization, currently at in the injectable PrEP implementation process? Great. I see some stuff pretty much all over the board. Most folks, though, are learning more about the process. And we have some implementation already going on for some folks. Great. All right. Thank you for letting me know in the Q&A as well. Let's go ahead and take a look at the next question. So for this one, you're going to rank the resources that you or your organization are going to need to institute an injectable PrEP program. So you're being asked to put these in the order that are going to matter most for you. All right, it looks like the answers have slowed down and they're moving. I see more answers are coming in right now, but it's looking right now that the highest ranked one looks to be institutional financial support. We still have institutional financial support sitting at the top, followed by provider education, followed by additional staffing. So thinking about nursing or supportive staff. Next, we have technical assistance. Finally, we have connection to a pharmacy or pharmacy staff, and then something else bringing up the rear. Okay. All right, let's go ahead and go to the next question. Thank you, everyone. All right, what would you say is the biggest challenge or barrier, for you or your organization in implementing injectable PrEP? As you're making your selections, we have staffing shortages, financial limitations, limited or no access to unique supportive staff. The volume of patients with interest is either too large or too small. Provider awareness, organizational buy-in, more than one of these, so a combination that you're looking at, or something else that may not be listed here. All right, and it looks like the main one appears just like with the previous slide to be financial limitations, followed pretty closely by a combination of these. So thank you, folks. Let's take a look at the next question. All right, and finally, what are you hoping to gain from today's session or from this learning series as a whole? For our choices here, we have acquiring general information about injectable PrEP, having some specific questions answered, gaining knowledge to improve or scale up an existing program, gaining knowledge to develop a new program, or something else. What are you most hoping to gain from today? Or from this learning series as a whole? So when I see gaining more information in the Q&A as well. All right. And it seems overall we're acquiring some general information while we're here. We're starting to scale up some programs. Glad to see it. All right. Thank you for taking a moment to answer these questions and let us know where we all are so far. And we're going to go ahead and hand things over to our first presenter, Dr. Daniela DeMarco. So Dr. DeMarco, whenever you are ready, feel free to take it away.
Thanks so much, Mike, and welcome everyone. Thanks for joining us today. So I'm going to go through sort of a big picture, or as it says here, bird's eye view of what an injectable PrEP program might look like. And, this is sort of gained knowledge from some of our work, but also some others who have collaborated with us, both on the TA side, both providing and receiving. So some of this will be sort of universally applicable, and some of it's a little bit more niched, but we'll go through the details. And, after this, you'll also hear from a panel of experts who've already implemented injectable PrEP programs in their organization. So before we hear from this, let's kind of start big picture. So in 2022, U of R CCP conducted a collaborative learning series as part of a SIBA request through New York Knows, which is located in New York City. And here CCP and New York Knows convened several clinical and non-clinical PrEP providers from their New York Knows funded organizations to participate in collaborative learning in what we call a peer-to-peer learning environment, with some external guest speakers on topics where expertise and experience gaps existed within the collaborative. And so we heard from a wide range of organizations and individuals, and from those hoping to implement injectable PrEP in the future, like many of, as you noted in the last couple of questions, and those who have programs already up and running and looking to expand or improve. So we've seen both of these groups are in attendance today, and hopefully we can share some knowledge that will help you. During the learning series, the collaborative identified several key components for successful implementation, which I'm going to share with you here. We looked at sort of several practices that, when you fine-tune them, could really become best practices within your organization. So as I start here with these key components, the first thing is building a multidisciplinary team for your PrEP program. Outline the tasks that need to be done, the staffing needs that you have to complete those tasks, selecting a medication and acquisition or prescribing strategy, and really starting small and then scaling up as you have continuous improvement throughout the program implementation process. So diving a little bit deeper into that, we have some pre-implementation considerations that this collaborative really highlighted as something that was important and worked for them. We did talk before that financing is not really a focus of today's discussion, but it will just include it here as part of the big picture. So of these, you see first, consider how you will obtain the medication for your clinic or your organization. There's something called white bagging or buy and bill, and I'll expand more on that shortly, but it's sort of how do you get the medicine and then how do you get it to your patient. Some of the tasks that I mentioned that you'll need staffing for include medication administration. This is an intramuscular injection. And in some states that requires a certain level of provider licensure, like a nurse, versus in other states, sometimes a medical assistant or an other sort of office staff can complete that. So it's not a same person or a universal application of who can do that. There's scheduling, particularly with follow-ups and reminders and so forth that go along with that, ordering and reviewing labs, making sure labs are on time, following up contact and retention, program monitoring, insurance coverage and prior authorization, and working with VivConnect enrollment when that applies to your patient. And then lastly here, identifying a population to pilot your program, as I mentioned on the previous slide, and reviewing and optimizing your process. So, one of the things that's important and not highlighted here, and again, not the focus of today, but I'd like you to keep this in mind as we move through the next couple of slides. Many clinics have found it helpful to create a list of the insurance companies primarily used by their PrEP patients or their general patient cohort. So when you think about these, they could be things like Medicaid or Medicaid managed care, Medicare or a supplement, and several private insurances. If you can make this list, you can then make note of whether long-acting cabotegravir is a medical benefit or a pharmacy benefit under these insurance companies. And that gives you a head start when you need to determine what prescribing strategy you can use for that person. And that goes back to this white bagging or buy and bill, which I'm going to expand on in a minute. The second item that you want to list sort of underneath these insurances and medical or pharmacy benefit would be, what are their prior authorization criteria? Because prior auth is almost universally required for this medication right now. So if you can have all that sort of lined up ahead of time, it really helps you have a much more informed discussion with your patient or client about the process of getting to injectable PrEP. You can really start from the beginning, but it also helps your staff in terms of how they're working through these programs. So let's move on to the next here. So as part of our work with New York Knows, we developed this flow, and we'll be sharing a PDF for you as well, but it's available on our website. And it goes through 8 steps that really take you from the patient interest or your client interest down to sort of getting through injectable PrEP and either continuing it or completing and transitioning off. So these are, again, items that are not terribly specific, but can kind of help you understand the various steps so you can understand the various staffing needs and organization you might need to at least get a program sketched out and started. So first you see that a person expresses interest in injectable PrEP. And then you move into the provider medical review. So your provider is going to be looking at things like medical conditions and lab testing to make sure that the medication is safe and appropriate for the patient. And they'll also be doing some detailed counseling and education on long-acting cabotegravir. So that would include things like any risks or potential side effects or adverse effects of the medication, the benefits that they perceive with the medication, the need for an intramuscular injection and what might be related to that. They'd also want to include the importance of adherence, the every 2-month follow-up, and really important to not miss visits and the need to go on pills if there's too much delay or a time to transition off, and having a very plain language discussion about pharmacologic tail and sort of what that means in the real world and real practice. The next would be step 2, where your support staff will delve into cost coverage. And again, not really the sort of point of today's talk, but people will touch on it in the last part of this, and then, the next part of the series. So here you're going to be determining medical versus pharmacy benefit. And your quick reference list that you've sort of devised ahead of time will help you with that. Obtaining prior authorization and evaluating need for payment assistance. So here, the medical benefit is essentially allows you to perhaps participate in a buy and bill program for those patients. The pharmacy benefit, you really have to write a prescription to like a specialty pharmacy, for example. And eventually you'll be identifying a list of pharmacies that you can work with collaboratively. If you get through step 1 or through step 2 and you're either unable to obtain cost coverage for that individual, even after working with VivConnect or various programs in New York State, for example, there's medication assistance for PrEP, just like there's medication assistance for HIV treatment related medications. So if you don't go through all these steps and you can't get through to a financing option that works, you may need to revisit oral PrEP options. Likewise, if you present all the options to a patient from the provider standpoint, and they're either no longer interested or there's a condition or a potential adverse effect or lab test that makes it not medically appropriate, you might need to go back to the oral PrEP options. When you get to step 3, that's where we delve into the support staff and care team leadership sourcing the medication. So here's where we get into some of the nitty-gritty details. Identification of participating pharmacies, which you see here, is really specific to something called white bagging. White bagging is really a term that describes where your prescription is sent to the pharmacy. Usually it's a specialty pharmacy. They'll fill the prescription and they send the medication directly to the clinic in most cases. The patient is then coming into the clinic to receive the injection. This is usually a good startup option for many clinics and organizations while you're trying to assess utilization and whether buy and bill is warranted. So what do I mean about buy and bill? This is where the healthcare organization pre-purchases and stocks the medication up front. And then when they have somebody come in and they've run it through their insurance and shows they're covered, they then go ahead and administer the medication and they bill the insurance company once the medication has been administered in the clinic. Generally, to purchase this upfront supply requires quite a bit of financing from the organization. It often requires whoever's trying to start the program to generate a business plan and recruit some organizational buy-in. You also want to, as I mentioned, ensure payer coverage prior to administering the dose to avoid the financial loss if that would be something that your organization is focused on or prioritizing. The white bagging option, when the insurance company has that as an eligible option for prescribing, does minimize the financial risk to the clinic. And again, it's a good startup strategy. So you see these options here. And once you have that, and again, many people who have a population with many different types of insurance, you may actually be doing both of these within your program. So you want to have trees for both options, and that quick reference insurance list with the prior auth criteria and whether it's a pharmacy or medical benefit will help you here. You move into step 4 after that, where the provider is actively ready to prescribe the medication. So they're either sending it to their internal pharmacy or their specialty pharmacy. And if an oral lead-in is required, it would be prescribed at that time as well. And you're also, by the time you get to this point, the initial HIV testing that you ordered might be out of date, depending on how long the process takes. CDC recommends that you have a negative HIV test within 7 days. So at this point, when you're doing a new startup, you may actually have to reorder the testing. And it does take a bit to get the medication if you don't have it on site, so you can order it at that time. And your support staff, right at this moment of ordering the medication, receiving it into the clinic, is going to start arranging the first injection visit and the follow-ups to make sure everything is laid out for the rest of their course. When you move into step 5, you've got the medication on hand in the clinic and you're ready to administer that to the patient. So in general, nursing is giving the first injection and then doing a post-visit check-in. So you want to have some additional staff, which you'll see on the next slide, kind of confirming your follow-up visits, but also engaging in monitoring and tracking. And one thing I didn't mention, but again, this will be sort of talked about more in the financing talk, is that CAB-LA is eligible for 340B pricing. I meant to mention that earlier and I forgot, apologies. So here, when we get to step 6, really focusing in on the follow-up and throughout the rest of these, continued engagement and retention in your program. So this is really the whole care team here working together to make sure that patients are coming in on time, that they're not missing visits accidentally, but also that if they do need to miss a visit for whatever reason that comes up, that you can make strategies there to either get them on an oral medication or maybe just move their visit around a couple days on either side, and you don't have to do anything other than that. But planning ahead and making sure there is a plan and your staff knows how to do these things is very important. So you're arranging subsequent injection visits. When you start injectable PrEP, your first follow-up visit for the next injection is 1 month later, and then it's every 2 months. And you're getting testing at these subsequent visits, including HIV testing and STI testing by the CDC guideline protocol. It's a good idea to have them see the provider every 4 months when they're starting out with this. The care team, again, is really focused on retention and care once you really get started on the program and the person is getting their injections. This will be every 2 months, which could be for a year. It could be less than that. It could be much longer than that. You need some sort of monitoring tracking system, and you need a couple of different staff cross-trained to help out with this so that when patients call in and they're worried about missing an appointment, they're going on vacation, what do we do? You have staff who are very informed and ready to give them the right advice about what to do with their medications. And then moving on to step 8, medication transition. So there may come a time when a person is ready to transition off of their injectable PrEP. And for this particular medication, it's recommended that they go on oral PrEP for at least a year afterwards because of the pharmacologic tail. And that is something that they can certainly discuss with their provider. And the rest of the care team is really continuing to manage engagement in PrEP services and retention in PrEP services by either injectable PrEP or oral PrEP if somebody's ready to make the transition. So with that, I'm going to stop sharing and I'll pass it back to Mike.
Thank you, Daniela. We have a question in the Q&A from Michael asking, is anyone using a rapid 4th gen testing for this? So, or what testing would be required for this?
Yeah, so it's a little tricky because you need an RNA, HIV RNA, in addition to the 4th generation tests for injectable PrEP. So what I can do is post the CDC guidelines, the link to the CDC guideline PDF document, because it has a nice table in there that shows you exactly what laboratory tests you need, including which HIV laboratory tests you need before starting.
Awesome. Thank you, Daniela.
Mm-hmm.
Let me see. So follow-up question about, a lab draw would probably be best then. So we'll make sure that the CDC PrEP guidelines are added into the chat, and I will talk with our team here about making sure that they're also sent out as resources from this webinar.
Yeah, you do have to have a laboratory-based testing to get started on this one. Thanks, Mike.
Thank you, Daniela. We do have a couple more that have popped up in here. So if a patient wanted to transition off the injectable medication, why or how would they need to be on oral PrEP and for how long?
Good question. So when there's what we call the pharmacologic tail, which really just means that with this long-acting medication, it stays sort of at an effective level to prevent HIV in your system for at least 2 months. So every 2-month injections. But even after 2 months, it's still in your system, but the levels are lower. They're not high enough to really effectively prevent HIV. And so that little, I don't have this with me, and it might have been presented last week, but essentially you kind of see sort of a little fall off in the curve. So you're at a good level of protection, and then it sort of falls down over several months and can remain in your blood, in your body for up to a year. And so you could still acquire HIV infection because the levels aren't high enough. And if you did acquire HIV infection, you could develop an HIV virus mutation that has resistance to that particular medication because of the low levels in the system that the virus is exposed to, which could make treatment down the road a little more difficult, because this medication is part of a drug class that's one of our go-tos for very effective HIV treatment. So if somebody has ongoing potential for HIV acquisition after they're stopping their injectable PrEP medication, at least for this particular medication, it's recommended to start an oral PrEP medication for a year following that to protect the person from HIV effectively.
Awesome. Thank you, Daniela. I see Luciano's also mentioned in here that they do HIV viral load testing for their PrEP clients. And then we have one more additional question in here that may get answered a little bit next month, but if you have some general answer for this, how can you best determine if you should approach insurance coverage via medical or pharmacy?
The insurance will dictate your ability to do either one of those things. So that's what you want to do up front, is kind of look at, okay, this person has Medicaid under XYZ managed care program, which option do they use, medical or pharmacy, and you'll go from there.
Excellent. Daniela, thank you. I see that one of our producers, Kristen, has added in the CDC PrEP guidelines to the chat, and we will make sure they're sent out as resources as well. Thank you, Daniela.
Thanks.
All right, we're going to shift gears now, and we're going to take a look at some of the programs that are here to talk about the work that they are doing. So we have 3 programs that you're going to hear from, and then they'll join us together to be on a panel after they each present. So again, we won't be looking at the Q&A during their presentations, but we will when we all come back together for the panel. So first up, we're going to hear from Toby Fugate from the Ryan White Wellness Center in Charleston, South Carolina. Next, we'll be hearing from Leanna Ramirez at the center in Las Vegas, Nevada. And finally, we'll be hearing from Justin Toro, who is with the Montefiore Medical Center in New York City. So Toby, whenever you are ready, the stage is all yours.
Okay, I'm just trying to share my slides here. Okay, so can you guys see the slides at this point?
Looks great.
Okay. So I'm Toby Fugate. I'm an infectious disease provider in Charleston, South Carolina. I'm the medical director at the Ryan White Wellness Center. We're part of a large nonprofit medical center called Roper St. Francis. And I just want to give you a little bit of background about our clinic, essentially tell you a little bit about ourselves. So we started out in 2000, and when we initially started up our program, we were offering case management and contracted medical services. And what I mean by contracted medical services, it was a situation where our patients went to various infectious disease providers in the community. So, there was probably 3, 4, maybe 5 doctors that they could choose from in the area to see. So they weren't actually seen in our office at that time. But later in 2010, we opened up a centralized clinic. And at that time, we saw our first patient on World AIDS Day. And we began to offer services in our own clinic. And then later in 2015, we added prevention services. We started providing PrEP, non-occupational PEP, and then also walk-in STD screening. And then, over the years, we've grown and grown. We're up now to around about 1,030 patients. And of those 1,030 patients, about 130 of them are PrEP patients. So our medical team consists of myself. I'm the medical director, and we have another physician, Dr. Abaraj, and 2 nurse practitioners, Hannah Whitesides and Don Bruner. And At this point, we provide medical case management. We have a on-site pharmacy, on-site lab, and we also provide a mental health program. So the main reason that I wanted to be on this panel is we were part of the Pillar study, and if you're not familiar with that, it's a study looking at implementation of long-acting CAB in the MSM population. And I went into this study with the hopes that we would enroll a lot of patients because it seemed like initially our patient population was very interested in it. But as we began to talk to the patients, a lot of the patients had hesitation. For example, there were several patients that very humorously would mention that they had been treated for syphilis so many times that they really weren't interested in an injection every 2 months. There were other patients that were truly just super savvy. They read about long-acting PrEP beforehand, and they came with some very legitimate questions. We had a few patients who even came prepared asking us about Levi syndrome. And if you're not familiar with that, it was sort of mentioned earlier, but not really by name. But it stands for long-acting early viral inhibition syndrome. And that's a situation where you would get long-acting PrEP, and even if you get your injections in a timely manner, truly get your injections on time, you could still become infected with HIV. And as the medication sort of washes out of your system, as was mentioned before, you could actually develop resistance. And the patients that discovered this on the internet and at conferences and such, they were very concerned about it. So as I mentioned, we have 130 PrEP patients, and we offered the study to all the patients. And at the end of the day, with their hesitation and also with the issues that we had with the insurance approval process, we actually only enrolled one patient in the study. And as we had study visits, it seemed to me that other sites throughout the country had issues enrolling as well for various reasons. In terms of the insurance issues, every prescription that we would send to the pharmacy, we would get a prior authorization, and despite our best efforts, we really just could not convince the patient or convince the insurance company to cover the medication. And one interesting thing that happened was the approval process was so cumbersome that some of the patients got fatigued with the process. According to the patients, they were getting multiple phone calls a day from both their insurance company and from the pharmacy. And some patients essentially just sort of gave up on the idea. But at the end of the day, we did enroll one person. And I'm happy to say that one person's doing really well on the medication. And they've come in regularly for their injections, and they're doing fine. But as I said, we just had a lot of difficulty getting buy-in from the patients. So when the panel discusses things, I would like to know what other people feel about Levi syndrome, and if other people ran into the same approval processes. So the benefits, I wanted just to mention some of the benefits. The one patient that we do have on the medication, he's very happy that he no longer has to carry around pills with him. He was the type of person that it really bothered him actually having pills at home in his apartment. So he's relieved that he no longer has to carry the pills with him, and he feels that it's more convenient for him and that it's easier for him to be compliant with this medication. And drawbacks are essentially what I just mentioned, the issues with patient buy-in, and then also issues with the payers. So that's all I have. If anyone has any questions, I'd be happy to take them.
Toby, we're going to save the questions for the panel. but some have started to come in, so we'll be ready to chat in just a moment. Thank you for going ahead and presenting. I'm going to hand things over to Leanna Ramirez now to talk about her program. And Leanna, you are on mute.
Thank you so much. Can you hear me now, guys?
Yes.
Fantastic. And you can see my screen okay?
Yes, we can see your screen and your slides.
Awesome. So hello, everybody. Good morning if you're on the West Coast. Good afternoon if you are on the East Coast. My name is Leanna Ramirez. I am the Chief Clinical Officer here at the center in Las Vegas, Nevada. I'm a pharmacist by trade. I've been a pharmacist for over 12 years now, and it always weirds me out to think of how long I've been working in HIV. So here at the center, we are a community-based organization to start with. However, we also have a clinic. It's called the Arlene Cooper Community Health Center. We are offering multiple services while at the clinic. So not only do we have HIV testing, we also do rapid start and primary care testing. We do PrEP and PEP, and we're also offering gender affirming services. I call it our baby clinic because when we started the clinic, we only had STI testing, and we only have 2 provider rooms. So kind of starting off a little bit small, but as you can see, we make a very big impact. We are celebrating our 30th year anniversary this year, so we're pretty excited about that as well. Another thing that I did want to mention is talking about our community partners and the importance of our community helpers in making sure that we have successful wraparound services for all our patients. So not only do we have Track B, they are a needle exchange machine. They actually have a vending machine that sits in our lobby so patients can access clean needles and syringes. We do have a pharmacy on site. As you know, it's been mentioned a couple of times how important the pharmacy is in this process and making sure that your program is successful. And we also offer linkage to care programs. So in addition to medical and health services, we do want to make sure that our patients have a place to live and have food and all of those other social services as well. So our baby clinic just recently expanded our hours, which we're really excited about. Not only are we open Monday through Friday, but we also have Saturday. And these past couple weeks, we recently opened Sunday hours. So our Sunday hours are open pretty short. It's only a 10 to 2 window, but we're pretty excited about that because not a lot of clinics and not a lot of primary care offices are actually open on Sunday. So we're kind of rocking and rolling there. So with that, I kind of wanted to talk about the demographics and the patient profiles that we are reaching here. So as you can see, we do have a very dominant male population here. But once we get into race and age, those pieces of the pie even out pretty regularly. So one of the things that we pride ourselves here is that we meet people where they're at, and we want to make sure that they feel welcome and that they feel safe. I also wanted to throw in some of the numbers that we're looking at. So on average, we are seeing about 500 people filtering through the clinic. As you can see, it did start to grow month after month with the increase of our hours. It still continues to grow. Right now, we're averaging anywhere from like 600 to 700 people filtering through. Not only do we do the HIV testing, but we are starting, as you can see, over 100 people on PrEP in general, typically each month. So those numbers are pretty intense and they're pretty high. And what makes us special and different is, of course, the people who work here, the people we hire, and the people who are just dedicated to making sure that our patients get exactly what they need when they need it. So with that, this is our typical workflow for patients who come in. So they walk into the front desk. We do take most major insurances, and they are sitting down with an advocate. The advocate, we call them HIV advocates, but they are also community health workers. And at that time, they're doing sexual histories, they're talking to the patients, they're educating them so that, you know, they can better understand any kind of risk reduction methods that need to move forward. They are talking about PrEP, they are talking about PEP. We do talk about sex. We ask how you enjoy sex, how often you have sex. If they, at that time, they're also processing the HIV results. They're doing an HIV test at that time in the room while they're having these conversations. We do alternate between an Instian and a Lear, but they are getting a rapid result right then and there. From there, if they are interested in proceeding with PrEP, we then room them and then they talk to a provider. And typically we don't start patients right on an injectable because we do want to make sure that they are negative. We do want to make sure that they are going to be adherent, and that's another conversation. But after the provider, we do have a phlebotomist on site who will draw all the baseline labs, and then we schedule their appointment before they leave for the day. So let's get down to the nitty gritty, right? Let's talk about our PrEP program and specifically our injectable PrEP program. So tips and tricks that we've kind of figured out and filtered out through working with the medication is that we have patients sign a letter of agreement. So all patients fill out the ViiV enrollment application form, all patients. I make them sign the application, and I also make sure that they all fill out there's a section for their financial information, and I do make them fill that out as well. And it just kind of makes it easier up front to have all that information submitted. But in addition to the ViiV application form, they do have to sign that they have received a negative HIV test. They sign that they agree to be tested every 2 months. They agree to be adherent. They understand the risk of missed doses. You know, we want to make sure that if we are going to spend the time to get this medication for the patient, that they're going to come back and see us, that they are going to stay adherent, and that the medication will be utilized. And I also think it's important to set expectations with the patient. The ViiV Connect program, we submit that application to the ViiV Connect program, and they generally come back to us and let us know if it's covered by medical benefits, if it's covered through pharmacy benefits, if it has to go buy and bill. At our location, we do not do buy and bill. We just don't have the capacity to honor that. But it's very important to have that relationship with the specialty pharmacy. So we're lucky enough to have the specialty pharmacy right on site, right outside our clinic door. So if a patient does show up and it does go through, we're able to kind of take care of them right away. But the specialty pharmacy helps with the prior authorization process. They help with our financial assistance process. They have the medication in stock for any reason if something, you know, is last minute. So I highly, highly recommend that specialty pharmacy aspect. And making sure that the patient understands, yes, we're doing everything today, but that might take a week, 2 weeks, depending on this entire process that we're going to do in the background while they're waiting to get the medication. So some other tips and tricks: when the medication is delivered to our office, we do put that in our electronic health record. So we do document receipt of the medication, and then when the patient arrives, we make sure that we give them their medication. When we store the medication, we actually stick a sticker on the box with the patient appointment, and we file that according to date, and then from there we file it alphabetically. So it's really easy to go in on, say, 9/19, and I can see whose medications are due, who has not come in, and who's expected for the next day. We do go back every week, and yes, there are people who might miss their appointments, and we might end up with extra boxes of medication, but we are actually really good about making sure that the patients do come in within their window. And remember, they have 7 days before and 7 days after their target date. So our team is a lot of training goes into it to make sure that everybody from the front desk to the provider to the billing, everybody knows how this medication is administered and delivered. Never underestimate the power of Excel. we've got an Excel spreadsheet, right? And we make sure that we have whose medications are coming in from what pharmacy and where, because it can absolutely get overwhelming. I mentioned we use a specialty pharmacy, but the PrEP program, they use a different pharmacy, and the insurance might require another pharmacy. So it's very important to kind of keep track of who you need to contact at what point. And that comes from experience, because we've had to work through that, calling multiple pharmacies and trying to figure out exactly where the medication came from. So I did want to include this in the last few minutes, because this is kind of our 340B medication profile. And as you can see, Apretude is part of the 340B program. And you know, as we progress, we are seeing more of these Apretude prescriptions coming through our clinic. And it still does not outnumber the traditional tablet. But again, I think it's definitely making it smart. And our patients are the ones who are coming to us, asking us for it. They, you know, the ones who we have in our clinic, they're fairly knowledgeable, and most of them are very excited to be on the medication. So with that, I leave you, and I'm excited to join the panel. Thank you.
Awesome. Leanna, thank you for your presentation, and we'll be happy to have you back in just a few minutes on our panel here. Again, we are holding questions until the panel. If you do have some questions in mind, you can start to put them in the Q&A, and we'll be ready to start the panel in just a moment. But first, I'm going to turn things over to Justin Toro, who will be our third presenter, and then we'll start the panel from there. So Justin, whenever you are ready, feel free. Justin, are you still there? Oh, there you are.
Hi, good afternoon, everybody. My apologies. You have to love a busy clinic. There's always something going on and happening here. So my apologies. But thank you so much. So my name is Justin Toro. I use he, him, and L pronouns. I'm the Associate Director for LGBTQ Services and Sexual Health for Montefiore Medical Center. We are here in the Boogie Down Bronx, New York City, if you did not know. Yes, I forgot the interpreters. My apologies to interpreters. Here in the Bronx, we are the sexual health clinic for Montefiore Medical Center. We've been around for now about 10 years, so we're coming up on our 10-year anniversary. Our clinic really started out of the need of folks living with HIV and their partners who needed some type of a preventative care, as well as generalized sexual health care. And as we know, working in the field, HIV and AIDS is really moving towards this umbrella of sexual health. So we want to really make sure that folks are well taken care of, that their sexual health needs are being done in a really great way, that are gender affirming, that are, you know, sex positive, that we're doing a harm reduction approach. So that's really kind of the basis of our clinic down here at Montefiore for the sexual health clinic. When it comes to injectable and Apretude, so we've been doing injectable PrEP now, I want to say maybe a little bit more than a year. For us, we are also part of a national study for Apretude. So we are part of the PILLAR study. That study is looking at basic standard of care that is happening in sexual health clinics or infectious disease clinics that are doing Apretude. So basically, they're studying how we administer the medication to folks, how our patient educators are getting insurances approved. So they're studying us as the clinicians to see how we made this possible, in hopes that we can kind of have guidelines produced towards the end of the study. So this way, more folks that are interested in doing Apretude have a really good standard of care guideline to have this and make this happen. So for us, the way our clinic works, so we are fortunate enough that we are grant funded through New York City Department of Health to do a lot of our preventative and our PrEP and PEP care. So that actually allows us to have 3 patient educators that are dedicated to those folks that are at high risk for HIV and those that are on preventative medication. The role of the educator is really, really important, as you all may know in some of your practices. The role of the educator is really to assist every patient on their journey when it comes to prevention. So anything that happens with insurances, the pharmacies, little things, if there's an insurance change or there's a pharmacy change or prior authorizations, all of our educators are really an integral part of that to make sure that the patient experience is a very good and positive one. So our medical providers really are able to focus on the medical care and making sure that the medical piece is well taken care of. And as long as we have those patient educators that are attached, more of the supportive services that we know folks really need are able to be taken care of. So all of our patient educators are in charge of their assigned patients' Apretude injections. So that's coordination with the pharmacy every month when there needs to be a delivery, prior authorizations that are done, and looking at some of those cost-saving programs for folks where the insurances aren't completely covering it. So, luckily, ViiV has a cost-saving program where we're able to get support for patients to do so. I would say for us, our biggest barrier, like probably many of my colleagues had mentioned before, is in regards to pharmacies actually being able to stock, carry, and deliver the medications. If they're buy and bill, if they're white bagging, brown bagging, if there are only pharmacy or medical benefits. So it's not like this was a very easy transition. We were really kind of figuring out the intricacies of getting all of these medications approved through the different types of insurance plans, pharmacy benefits, and things like that. So we've really been able to, luckily, we as a hospital, we have a community pharmacy, but also we've been able to link up with some of the specialty pharmacies in our surrounding area that are able to do some of the work that our pharmacy hasn't been able to do. So again, luckily, our patient educators are very well involved in the process. And I really think if we did not have patient educators to do this, we would not be as successful as we can. Our case managers, our patient educators, as I mentioned, are a very key part into this. They reach out so the patients reach out to the educators probably more than they reach out to the doctors, which is a great thing because you want to make sure you have, somebody in your corner to explain certain things. If the provider, maybe explaining something that they may not understand, the educators can take extra time to provide the education and the information that they need to understand their risks, how the injectable works, their kind of time frame in between being able to get it before, or if they're missing, how that works. So really, as I mentioned, our patient educators are a huge piece in making sure, that this works. For Montefiore, part of a large entity in a large hospital, there was a lot of discussion about this. But, luckily we had Cabenuva that kind of hit the market first. So we were already having conversations about injectable medication and what that would look like in practices and in the pharmacy. So because of some of the experience we had with the Cabenuva, we were able to apply that to our Apretude and our injectable PrEP to make sure that it's done well and it's done correctly. We've had a really good success with individuals that are on injectable PrEP with us. I believe right now we are about 42 to 43 individuals that are on the injections with us for injectable PrEP. So if we divide that by our 3 educators, you're looking at about 11 to 12, maybe 15 patients that they have each. So it's a little bit more manageable now in the beginning, but we know that the success and the popularity of the injectable will definitely increase. So we'll want to make sure that we are prepared for that influx of folks that are going to be coming in and that are going to be getting the injectable. Some of our workflows include having folks, reach out to us that they're interested in PrEP. We get a number of referrals from our emergency department for folks that are going in for general sexual health stuff. We follow up with them regularly from the emergency department. And we actually have a really good emergency department team that when they identify somebody that's a candidate for PrEP, they will make sure that they refer them over to us. If they're a PEP patient that they're seeing in the emergency department, we're getting referred so this way we can follow up with them. And a good majority of our PEP cases do convert into a PrEP case. So for all of our individuals come in, they are all evaluated by one of our medical providers. Full sexual history is taken, any previous STIs, things like that. And even the folks that don't identify that they're interested in PrEP, during the triage process, we have a screening that we have all of our nurses use to make sure that, hey, you are a little bit at high risk. Have you heard about PrEP? If not, here's some educational material. You'll probably speak to the doctor a little bit more about it. And if you're interested, we can get you started today. And if not, at least they have the educational material and the information in their hands. So again, during that screening and triage process, we are capturing folks that we may have missed, or maybe the emergency department missed, or maybe their primary care doctors had missed because they're not having the sexual health talk. They're not asking about partners. They're not asking about what orifice people are engaging in sex in. There are so many folks that engage in anal sex do not feel comfortable disclosing that they engage in anal sex. And that's a missed opportunity for a swab to happen to possibly identify an STI in that orifice. So we just really want to make sure that we're having open, honest conversations with all of our patients, that everybody's engaging in some type of sexual, activity, whether it's by themselves, with a partner, with many partners. We don't judge. We want folks to have a really wonderful, enjoyable sexual health experience. We just want to make sure that wherever or however they're engaging in sex, we are testing them for STIs and making sure that they are good. And then that follow-up, just really the educators are really involved, that they're coming in for their follow-up appointments. And it was a struggle in the beginning, not gonna lie, but with all new things and with change, it definitely takes time and lessons learned. And luckily, we've been very fortunate to really get our workflow to a place where anybody that's coming in and requesting the injectable can really start on it same day, and we can get that process same day. So I think that's my time. It is.
Awesome.
Mike is
Thank you,
smiling at me.
Justin.
So
You know that smile.
yeah, so thank you all so much. And again, I have interpreters. I apologize for my swiftness. I'm a New Yorker. I apologize. I talk really fast, but we'll be here for questions afterwards.
Absolutely. So I'm going to take a moment to welcome, all of our presenters onto our panel piece. So we'll go ahead and shift gears to that. And I'll also invite Daniela as well, just in case there are some general questions or any follow-up questions regarding the flow, for Daniela to be a part of this discussion as well. So that being said, feel free, if you've got some questions, to go ahead and add them into the Q&A. I will be keeping an eye on time. We are ending at 2:30. So I will get through as many of the questions that come in as we can. So the first question popped up, Toby, during your presentation. So wanting to know, does Levi syndrome happen when injectable PrEP users stop using PrEP, or, genuinely while they are actively and accurately using PrEP?
So it's my understanding that in HPTN 083 study, that there were, I think it was 6 patients that were receiving their Apretude on time, and those people became infected and potentially developed resistance. I would be in one thing that we've been struggling with here is what to make of this. So I would be curious, what do the other panelists think?
We haven't personally seen any cases in our practice. We have a small scale injectable PrEP program at University of Rochester. And but yeah, I know, as you said, that there were a small sample of cases of seroconversion that occurred. And essentially it was just the principle of the syndrome is just that it's difficult to detect because people don't have the same symptoms, and there's a delay in the positivity of all of the test results. And thus the sort of additional RNA or viral load test that's recommended now for injectable PrEP.
And I had mentioned that there were some patients who were reluctant for that reason, and all the providers explained to them that we would be doing, HIV virus loads in addition to the standard testing, but we really just can't get them to buy into it. It's the community here's very small. And once word gets out about something, it seems that it spreads quickly. So I think that may have something to do with the reason that we had such difficulty getting people to buy into the idea.
Awesome, thank you. We have a question in here that also came up during Toby's presentation from Jacqueline. And I might just kick this one to Daniela, but then I want to hear about, what you're doing in your practices as well. So noticing a change in CDC guidelines that don't mention anything about timing or frequency of screening for hepatitis B or hepatitis C. Is screening still going on annually for MSM? Are we checking for immunity at baseline? What's the guidelines and what are we all doing?
Okay, so I think there's a couple different reasons for both the screening. So there's age-based screening for hepatitis C at a national level, which is pretty much all adults into the late 70s. But then also certain states have their own age-based and risk-based screening recommendations. So you might want to check what your state has, if any guidelines exist. But in general, I would consider hepatitis C screening similar or the same protocol between injectable or oral PrEP individuals. So whatever you're doing for one would be fine for the other. And for certain populations, CDC recommends more frequent Hep C screening. For example, people assigned male sex who at birth who have assigned male sex partners. I think it's every 6 months, maybe, or twice a year, but that would be in the guidelines as well. And then for hepatitis B, one of the primary reasons you're checking it at baseline for people on oral PrEP is those oral PrEP medications have activity against hepatitis B as a treatment standard. And so if you abruptly stop your oral PrEP, you could flare a hepatitis B infection. And so there's a little bit of a different reasoning about why you're checking that, but essentially you're going to sort of check hepatitis B and then you'll immunize someone if they're not immune, but you don't necessarily need to sort of monitor that serially over time. And of course, if any of the others have a comment on that, please go ahead.
So no, we approach it the exact same way that you mentioned. We tend to get hepatitis C once a year. And then, as you mentioned, with hepatitis B, if we find out someone is not immune, then we'll immunize them.
I see some head nods from Leanna, and I saw some head nods from Justin at the start. Are your protocols similar or the same then?
Yeah. Okay. Ramirez, good.
Yeah, they are the same. And, you know, we try to adjust the labs as needed for the patient, right? So they don't always need the same labs every 2 months to come in. So we want to make sure that, but we are drawing that RNA every single time. So the lab part can get a little bit tricky. So just making sure that, you know, you do the best by the patient.
Excellent.
Yeah, and I was going to mention for us, I mean, we're in the vein anyway. So if we're in there, what's another tube to draw? And, you know, particularly for our MSM folks, we're checking hepatitis C quite regularly. I mean, let's be honest, we know patients aren't always 100% about their activities that are going on. So for us, we prefer to provide some type of blanket security in regards to, you're here, we're doing the labs, let's get this lab done while we're in the vein anyway. You know, we want to make sure that we're monitoring you as closely as we can, because also we know folks like to know, well, hey, I was diagnosed with this. Can you tell me a time frame? And if somebody hasn't been tested for hepatitis C in 2 years and all of a sudden they have a positive result, there's really not knowing what activity or what partner or something may have put them at risk. So we really want to make sure that we have those timestamps so we can accurately and confidently tell folks, well, look, something in the last 3 months happened where this actually did convert to positive. So definitely, you know, again, insurance are covering it with no issues, no problems. It's part of generalized sexual health care. So while we're in there, what's one more tube of blood?
Absolutely. Thank you. So we know that, you know, in the guidelines, they talk about an optional oral lead-in before injectable PrEP. Are each of your programs doing the oral lead-in for yours, or is it like a case by case? I see some, okay.
So for our clinic, the patients that were going into the pillar study, our IRB made us make a decision up front as to whether or not we're going to use the oral lead-in or not, and they made us stick to that decision. So at least for the study patients, we did use the oral lead-in, but I certainly don't think that it's necessary.
It seems like we've got some similar thoughts across the board among our panels, because I saw how the head shakes looked there.
If I may, I was going to mention in regards to that. So we are actually having folks remain on their oral lead-ins after their first injection is given. Reason being, there will not be enough concentration of the medication during that initial injection for someone to confidently go back into the world to say, I have protection, I can engage in my sexual activity. So while people are actually getting that injection, they are remaining on an oral medication for at least 1 to 2 weeks until that full concentration can be reached of the injectable. So this way we have no possibility of that, in that very closeness of not having the built up concentration, where that's really where we get into tricky possibilities of someone actually contracting HIV if there is not the full concentration in the body. So same thing, it's kind of case by case basis, but those that we are, starting the oral lead-in, we'll have them take it for 2 weeks, make sure that there's no side effects, that they're good. They'll come in for their injection, and then they'll remain on the oral lead-in for the remainder of the 2 weeks, and then they're on their injectable schedule.
Excellent.
And just kind of one more tidbit, 90% of our patients who come in, we start them on a tablet or a pill, right? We can't automatically start them on an injectable. So, they already have a tablet that they're taking. So by the time we get the injectable, we go right in.
Excellent. Toby, there was an additional question in here from Shayla, wondering if you're able to share the results of the study with participants, or is it still ongoing?
The study just ended just a few weeks ago.
So results to hopefully come before too long. Thank you, Toby.
And Justin, just a question for you. What I found here is my colleagues in North Carolina, my colleagues in Georgia, they were, and in Florida as well, they were having an easier time getting the patient on the drug. Whereas we struggled, my colleagues in Tennessee struggled as well. So I can't help but to think that it varies from state to state, based on the insurance. And, clearly the insurance in New York is probably better than the insurance in South Carolina. Did you have any experience with the states around you?
So for tri-states, so New Jersey and Connecticut, it was similar processes of ours that we were running into. So again, really identifying that buy and bill pharmacy, one that'd be able to do it, that working with medical benefits. I definitely agree with you. It definitely varies state to state. But also like with New York, we just have the big push now for the Medicaid prescription plans to change. So that kind of threw everything into a tizzy and just kind of threw us all off our game. But I would definitely say between us and New Jersey, we had very similar experiences with a lot of the barriers that we were running into. So we definitely have folks that are requesting the medication first appointment. We have to sadly say, we wish we were that good, but we're not that good that we can get you this injectable on your first visit. But again, like was mentioned, we'll definitely start the oral medication and work on it as quickly as we can and get those folks on the injectable.
So for the patients that you started on, let's say Descovy initially, did the insurance give you pushback when you wanted then to transition them from Descovy?
Oh, no, luckily, for us, we did not run into any of those problems. Okay. It was just in regards to, making the need for medical necessity, why this was. But I would say of our 40-something patient, that maybe happened only once or twice, where the insurance company was like, hey, we just paid for a full month of Descovy. Why all of a sudden? It's like, well, you were taking too long with the PA process to approve it, and we couldn't just have the patient going out there unprotected, so we had to get them pills. So, it's just really making the insurances aware that, this isn't a perfect science. Yes, somebody may have just gotten a full 30 days of the pills, but that doesn't mean that they can't keep that for the just in case if they have to go off of the injectables. So that's how we've been kind of explaining it to the insurances, and they've been reluctantly kind of approving, but it's really on how you state your case to the insurance and have them remember, you're the insurance company, you're not the doctor. You have to listen to us. We know what we're doing, but we know that fight's always happening with the insurance companies.
Yeah, that's one of the most pleasurable things of my day is to argue with the insurance companies. It gives me a chance to yell at people.
Well, let's ask about insurance here.
I was going to say, we've been through that a few times, and sometimes it's just no, and they won't do it. And they'll say a person has to fail an oral regimen first. And what exactly does that mean? I'm not sure, and they're not sure either. But oftentimes we have to sort of explain to patients that your particular insurance requires some number of months on the oral medication before they will cover this injectable. And some of them just won't do it. New York State has pushed some policy change recently, which I think Justin alluded to earlier, but there's been some recent policy change where they're trying to make it so that injectable PrEP is sort of considered similarly to the oral PrEP options when it comes to PrEP in New York State, and offering copay coverage. So generally speaking, in New York State for PrEP, you wouldn't have to pay a copay no matter what it was. So that has helped a little bit too with the rollout, because the copays are also fairly high for some people, where it's a pharmacy benefit.
So my follow-up here, we have a question in here about insurance, and I know we're not going to get to all the questions that, are in here. And, with Vive Connect, we're thinking about sort of like Gilead's piece of connecting people, patient assistance. That's what Vive Connect would be. What, guidelines or support do you have for patients who are uninsured?
The Vive Connect program is very, very good. Those are the one instances where I'm like, okay, we can probably get you started fairly quickly and get them set. So yeah, Vive has done a great job of offering assistance to the uninsured patient.
Excellent. I did see there was a question. We will be sharing the slides and resources, including the workflow that Daniela shared as well. But looking at, we're getting close on time here, and I do have to keep us moving. And I hate that we have to cut our conversation short, but what is one thing that each of you would like to leave our participants with? Like, with where they are at Injectable PrEP right now, what's something you'd like to leave them with before we close?
I think don't give up, right? We are the patient advocates, so we are to help people, help patients. So where there's a way.
Yeah, and I agree with her. It seems like with the panel, there were two good experiences and one poor experience, but we're continuing here to try to get patients onto the medication. So certainly don't give up. It's been my experience that when a new medication comes out, the first year the insurance companies are very difficult to deal with, but then after a while it seems like they loosen their reins and allow you to prescribe the med.
I would mention, kind of the same thing. It is a struggle. It is a battle, but one that's worth fighting, particularly for our patients, just because we've seen really great success and adherence to the injectable that folks are coming into. It alleviates that pill burden. It alleviates the stigma of walking around with the pills. Everybody knows what that little blue pill looks like. So we all know that's Truvada. So it really helps eliminate a lot of the stigma for folks. But also, I think because of the frequency that folks are coming in for their injections, we're able to test them for STIs a little bit more regularly. There was this whole thing of when Truvada came out, well, Truvada is going to give people the allowance to have unprotected sex. So we're going to see a rise in STIs. STIs have always been on the rise. That's just a thing. But now we're at least to confidently be able to say, hey, we can prevent HIV. Let's make sure we're testing you regularly for all other STIs. So definitely a battle that's worth fighting for. And I would definitely say for folks, having support staff to help with this process is a huge step in that process. So if you can find the funding, if you can carve out the money, definitely having some type of navigator involved in the process will help your flow just immensely.
I guess my thought was just like Liana's, don't give up, but not just for the provider, but for the patients. I think it's just important for us to set them up with some realistic expectations and not sort of say, yes, we can definitely get you this injectable option. Hopefully we can, and we're going to keep trying. But even if we don't, there's these other options for you. A lot of people already on injectable PrEP are very PrEP savvy people, and people who expressed interest early on and are getting on the medication. But this, really is an option that we want to expand to everybody, so we can have a lot more equity in terms of PrEP uptake and PrEP dissemination. So, some of these folks are not PrEP savvy. They haven't really been engaged in PrEP. And so I think it's just important to make sure you kind of lay it all out there. These are all the options. They all work really well. We like X, Y, Z for these reasons and this for these, but there's different options, even if we can't get this one for you.
Yeah, 100%. It's nice to see that, we're finally adding even more to the toolkit for prevention here. And I really love getting to hear about your experiences in your clinics, making sure that people are aware of options, that they can connect to the option that works best for them. And, maybe a couple years from now, we're going to be talking about, vaginal rings and microbicides as well, because we're adding more to the toolkit. I know that there are more questions in there, but keeping an eye on time, I've got to keep us moving. I know that there were some questions in there about financing as well. Keep in mind that the October session is going to be all about financing, so your questions can be answered there. You're going to receive an email shortly as well that's going to have resources from today. You can always reach out to us if you have additional questions. And I can always reach to Daniela from there and reach to our speakers from there as well if you've got specific questions or are looking to connect with our speakers. Again, for my panelists and for Daniela, thank you so much for being able to be a part of this today. It's been great hearing about your experiences and hearing about what you're doing on the front lines with injectable PrEP. So thank you for
And Doxy for PEP for all. Doxy PEP for all.
Doxy PEP for all as well too. Thank you. You've got a QR code on the screen here. If you can please take a moment to complete the evaluation for this session in the webinar series. One of our producers will also put the link to the webinar in the chat in case you're unable to scan the QR code here. Oh, thank you, Holly, for putting it in the chat. And thank you for attending today. As a reminder, this is part 2 of a 4-part series. We are recording these sessions and we'll make sure resources go out. The next session is going to be hosted by our friends at the Washington University at St. Louis, their capacity building team, and they're going to specifically be looking in at financing injectable PrEP. That session is scheduled for Tuesday, October 17th. Same Eastern time at 1 o'clock, so morning for our folks as you get out west, but same time, just October 17th for that. Thank you for participating today. I hope that this was helpful for you. I hope that you've gotten some information for your own programs, and I hope to hear about your programs maybe at a future conference or in a future webinar as well. Thank you for attending.